Welcome everyone to the panel in Practice Management in Integrated Primary Care, Innovations and Expansions in COVID-19 and Beyond, hosted by the Clinical Health Services Council as part of the Society for Health Psychology, Division 38, and co-sponsored by the Society of Clinical Psychology, APA Division 12. It is my pleasure to welcome you all here today. My name is Madeline Conser. I am a graduate student in the Clinical Psychology program at Rosalind Franklin University of Medicine and Science, and current intern at the University of Chicago Medicine in the Adult Health track. I am also proud to be the past chair of the Student Advisory Council of Division 38. I look forward to introducing our panelists shortly, but first I wanted to review a few housekeeping items. First, our program will be recorded. Anyone who speaks during the panel, for example, to ask a question, is agreeing to be recorded and is granting permission for the recording to be posted on our website. Second, we encourage you to put your Zoom on speaker view rather than on gallery view for the best experience. This webinar is eligible for 1 continuing education credit under the Society of Clinical Psychology Division 12 sponsorship. CE evaluation information will be sent through email shortly after this webinar. We will leave the evaluation open until 5 p.m. Eastern Time on Friday, October 22nd. CE certificates will be sent via email within 5 to 10 business days after the evaluation period closes. All participants are invited to submit feedback through the evaluation form, even those who are not seeking credit. Today's program includes a structured discussion with our distinguished panel and then an open Q&A segment. You may use the chat function at any time to share your questions and/or perspectives, which will be saved for the Q&A segment at the end. You may also unmute during the Q&A segment to ask your questions aloud. It is my pleasure to introduce our wonderful panelists for today. First, we will have Dr. Erin Swedish, Director of Health Integration through the Office of Health and Healthcare Financing at the American Psychological Association. Second, we will have Dr. Jessica Martin, Education and Implementation Specialist at the VA Center for Integrated Healthcare. And finally, Dr. Stacy Obeid, Associate Professor, the Department of Family and Community Medicine Director of Behavioral Health Education, the Family Medicine Residency Primary Care Track Coordinator, and working for the psychology internship from UT Health San Antonio. Now I will turn it over to our wonderful presenters, starting with Dr. Erin Swedish.
Thanks so much, Madeline. I'm so happy to be here today. Like Madeline said, my name is Erin Swedish, and I am the Director of Health Integration in the Office of Health and Healthcare Financing at the American Psychological Association. I am a trained pediatric psychologist and worked in hospital settings until 2018, when I decided to go back and get my executive MBA, and I've been working at APA since the summer of 2020. At APA, I really focus on health psychology, and so I'm happy to present today on the American Psychological Association and what we've been doing in integrated primary care, especially since the pandemic. Just going to share my screen real quick. Can everybody see that okay? Okay, great. So, as you probably most know, through the pandemic, our work in integrated primary care has been increasingly important. We know that Americans have experienced increased rates of anxiety, depression, trauma, and with more people reporting symptoms such as anxiety and depressive disorder. So during this time, it's been even more imperative to make investments to improve how mental health care is treated in our country and make sure that mental health is more accessible to those who need it. So the pandemic has really demonstrated that increasing access to mental health care is paramount. And it is clear that our mental health is as vital to our well-being as physical health. So a few things that, projects that I've been focusing on at APA since the pandemic, and one of them is the Integrated Primary Care Advisory Group. So the Integrated Primary Care Advisory Group was one of the first projects that I began to work on. We know now more than ever that psychologists play a crucial role in integrated primary care. And it's important for APA to develop and organize an effort around reimbursement for integrated primary care, and also have a response to psychiatry's collaborative care model. With the growing issue at a national and state level, especially during the pandemic, we want to make sure that we create space for psychologists. And so that was sort of the driving factor behind the Integrated Primary Care Group. We really wanted the group to focus on address issues specifically to integrated behavioral health in primary care. And so some of these issues that we work on include primary care model articulation, payment structures, billing codes, and legislation. And so the group is comprised of members who were nominated by presidents from key divisions, such as Division 38, 54, sorry, forgot to click on. And it comprised of 16 members, advisors. So this group has really had a response to the collaborative care model. And one of the first things that we worked on was state legislation. So this was the Montana bill. And basically this bill was presented to provide coverage for the collaborative care model. And we worked with Montana Psychological Association to make sure that the mental health parity bill was to include coverage for services provided through the collaborative care model or primary care behavioral health model. So really initially it just focused on collaborative care model, and we were able to revise the bill to include PCBH. And this bill will go into effect in January of 2022. More recently, a federal bill was introduced, actually it was introduced on September 10th. And this is called the Collaborate in Orderly and Cohesive Manner Act. And this bill was actually set to provide $30 million a year to support the uptake of just the collaborative care model. So, and it's only the collaborative care model as defined by CMS under a limited set of reimbursement codes. So as you can imagine, APA has some strong concerns about the federal legislation, and that it kind of only promotes this one narrowly defined version of integrated primary and behavioral health care. And we really believe that it should instead sort of give providers the flexibility to develop programs based on their patients' needs and their local resources, instead of sort of just promoting this, one model, collaborative care model. And so we really believe that there's no one-size-fits-all approach, especially during the midst of, this mental health and substance use disorder emergency of the pandemic. And so we really believe that all hands should be on deck, and there should allow a full range of evidence-based models for making sure that we're increasing access for behavioral services within primary care. And so, oops, sorry, go back. And so so we really believe Congress should take like a different approach in expanding access to integrated care. And the IPC advisory group has assisted APA staff in working with psychologists to sort of educate members of Congress about the effectiveness of other integrated primary care models and other interventions that provide sort of improved patient outcomes. They've also been influential in providing resources on the effectiveness of sort of non-COCM integrated primary care models, and identifying psychologists that can join APA in meetings with the House and Senate offices. So it's really been a collaboration between our office and the advocacy office, and then IPC, in helping these efforts. And these are ongoing efforts. So we hope to provide an alternative bill that includes the full range of evidence-based behavioral health integration models. So that's a little bit about the IPC group. Moving on to akka. So akka is the Advisory Committee on Colleague Assistance. It historically was a committee that aided in sort of legal and ethical issues. And in the past year, it's sort of been reorganized, and the focus has moved to self-care and wellness for psychologists. And this has been really important amid the pandemic. And so I've worked with the committee to publish a series on self-care and wellness articles that focus on sort of reconceptualizing what self-care is, and sort of move away from the kind of do-it-yourself way of self-care, and sort of recognize that self-care is about both the individual, but also that it's sort of exists in this system. And that self-care and wellness should sort of be examined through multiple lenses: the lens of community, culture, and policy, and power. And we actually, one of the articles that was published in the Monitor over the summer, this past summer. And it's one of the top 10 most read pieces of content that APA has produced this year. Next, some other things that we're doing out of our office is we are a member of the Primary Care Collaborative, which is a nonprofit multi-stakeholder membership organization dedicated to advancing sort of effective and efficient health system built sort of on the strong foundation that primary care in this patient-centered medical home. And the group is really active in pushing for alternative payment models, including integrated behavioral health care. They're also involved in the development of looking at a new behavioral health framework that helps inform alternative payment models. And so APA has had increasing involvement with this group. Dr. Stephen Gillespie, myself, a staff member from advocacy, attends these meetings. I'm a part of a work group on mental health integration, and Dr. Arthur Evans has actually moderated a session for the PCC. So very involved in that organization. Next, I think it's important to talk about, it's not specifically related to integrated primary care, but it's actually related to all psychologists, and there's some important implications for integrated primary care this year. So each year, the Center of Medicare and Medicaid Services releases a proposed rule on the following year's Medicare fee schedule, which includes changes in policy that will directly impact all psychologists and their patients. So when reimbursement for behavioral health services is reduced, we know that sort of has a trickle-down effect on all services for those who most need it. So APA every year urges the entire discipline of psychology, whether you're a practitioner, a scientist, a student, educator, whoever, to make comments to CMS. Because when CMS makes policy decisions regarding telehealth services or what CPT code psychologists can use in Medicare, these policies really influence, these policies really sort of influence policy decisions of state Medicaid programs, private insurers, and the VA. So if we can get a large number of cohesive and unified comments from psychology, this can have a huge impact on decision-making around the proposed policies. And this year, there was implications related to telehealth, especially around health and behavior assessment intervention codes, remote therapeutic monitoring, and conversion factor. And so just to give you a little bit of data, This year, there was a new record for number of comments that were submitted by psychologists at 9,814. And then last year, psychologists' comments represented 17% of total comments. And this year, we represented 28%. And then last year, we had 37 state, provincial, and territorial psychological associations submit a comment letter. And this year we had 45. So that just kind of concludes a few things that we're working on at APA to better advocate for integrated primary care. And I'm going to hand it back over to Madeline. Thanks, everyone.
Thank you so much, Dr. Swedish. If people have comments or questions, please feel free to add them in the chat and we'll address them in the Q&A section. I will now turn it over to Dr. Jessica Martin.
Okay, can you see? I was debating which way to do this, to do it in slide presentation mode, then share, or what? Can you see now?
Yes.
Okay, and the right view? Great, okay, thank you so much. Okay, good afternoon, so happy to be here. As Madeline mentioned earlier, I'm Jessica Martin, and I'm with the VA Center for Integrated Healthcare. I'm a clinical psychologist by training and serve as an education and implementation specialist to support the execution and sustainment of integrated primary care within the VA healthcare system. So the VHA employs over 1,800 behavioral health providers working within an integrated primary care settings nationally. So the COVID pandemic really required a quick pivot in the way that we deliver care in IPC. And so in this segment, I'll be sharing some lessons learned regarding shifts in IPC operations, metrics, and training during the COVID-19 pandemic, with the goal of giving you some takeaways to apply to your own setting. This presentation draws from resources we've developed at the Center for Integrated Healthcare to support the delivery of IPC, and also the lessons learned from the entire VA integrated care community. I do want to extend a huge thank you to all who have contributed. So the care, team-based care, we typically think of the care team co-located in one area, working together, seeing patients, sharing space, walking from room to room, and coming together as team members before, during, and after the patient's appointment. COVID has definitely changed that. So whether all team members are virtual or some are in clinic, keeping a physical distance, things have really looked different in most clinics.
Okay, it's 313.
Oh. Okay, great. So our colleagues at the VHA Office of Mental Health Operations SMITRIC Program Evaluation Center took a deep dive into the data regarding how care has shifted during the pandemic in VHA. So you can see that up until COVID hit, in-person care was by far the most common type of service delivery represented, and you can see that there in the light gray. When the COVID pandemic was declared a national emergency, care shifted extremely fast. So in-person, individual and group services each decreased by 90%, while individual telephone care rose by 147%, and clinical video telehealth into the home services rose by 645%. So you can see that the overall amount of services being provided took an initial dip right when COVID hit, but has really rebounded over time. The data on this slide only goes through July of 2020, but over the last year, encounter volume has really returned to at or near pre-COVID levels across VHA. And while in-person care has rebounded a little bit too, by and large, this is still the trend of the case the kinds of delivery that we're still seeing. Huge amounts of telephone, more CBT to home, and then in person, kind of chugging along just a little bit at a time. And that dips as spikes occur in different areas. So here are some key lessons learned about IPC operations within a virtual environment. So accessibility is an integral part of team-based care. You really have to be present and available, even while virtual. So using real-time communication tools like Teams messaging, video meetings, and texting can really help promote a feeling of being virtually co-located. Maintaining an open door policy so that it feels like you're operating within the same space is really important. Being accessible means you're always ready for a warm handoff, and you have to make sure that warm handoffs do remain the norm. Building in formal backup systems so that it's easy to pivot if someone is out unexpectedly, or if one form of technology fails is really important. And that brings me to the final point: know your technology and share your knowledge with the larger team. So that's really one way to make sure that everyone has the knowledge and the skills needed to provide care, no matter where the patient and care team are located. So accessibility, mentioned on the previous slide, going to talk about it again. It's really always been key. And before COVID, we saw many teams operating with one embedded BHP for a set number of primary care teams. This model allows for each primary care team to have a readily accessible and familiar BHP to be that go-to person. The downside of this model is that if the BHP is out or unreachable for any reason, then those care teams are left uncovered. Teams often have informal workarounds that may involve walking down the hall to access different BHP or some other coverage system. But when COVID hit, it became much more difficult to operate on the fly, and teams could really feel kind of lost in virtual space while trying to find the support that they needed. So having formal systems in place for backup coverage is essential when providing team-based care virtually. One operational shift that we saw during COVID involved consolidating resources across clinics and providers. So if you typically had one person assigned to the 4 or 5 primary care teams, like we saw in the prior slide, you could take your 3 BHPs and have them collectively provide services to 12 or 15 teams. This really creates a wonderful backup system. It allows for cross coverage and maximizes accessibility. To continue to maximize the continuity of collaboration in this model, a single BHP remains that point person for a particular primary care team, which would involve attending huddles, team meetings, proactive population outreach activities, and being that general go-to person for questions. But the team of behavioral health providers are available for the immediate needs, including those warm handoffs from all of the primary care teams. So the same-day warm handoff is one of those hallmarks of integrated primary care. Collaborating to respond to the patient's needs in real time demonstrates that the team cares and that the patient matters. Research shows us that seeing the patient same day results in benefits to the patient that truly make a difference. So decreased wait time, decreased no-shows, increased engagement, among many other positive outcomes, are all very important in the lives of the patients that we see. So real-time virtual warm handoffs can be done. So you can provide handoffs via clinical video telehealth with platforms like Zoom, like we're in today, and WebEx, or even by telephone if you need to. As I mentioned before, it's really critical to know the platform or the software that you're using and make sure that you practice. But once you have a process in place, it can be pretty seamless. So often, the PCP is seeing a patient via clinical video telehealth and then identifies a behavioral health or health behavior need. The PCP sends a message to the BHP via some modality like Teams, and then the BHP can respond with their availability. The PCP can then just copy and paste the telehealth session information into the Teams chat, and then the BHP joins the telehealth session by clicking on the link. The PCP then provides the introduction and explains how the BHP can be helpful. All right. And then the PCP can just exit the session, and the BHP can continue on and gather, do a functional assessment, gather any needed information. So one of the lessons learned throughout COVID has also been how technology can be leveraged to both extend services and resources to patients, and also to further team-based collaboration. So providing self-directed care resources can be very helpful, especially in times of reduced in-person care. Recommending mobile apps and web-based courses is an opportunity for team members to really be speaking the same language with patients. During COVID, one healthcare facility trained 43 staff from a variety of disciplines as mobile health ambassadors, resulting in nearly 1,200 patients being introduced to mobile apps in just the first 3 months of this initiative. Some patients will use the apps and resources on their own, and some may benefit from routine check-ins with the BHP to help monitor their progress and problem solve any barriers that they might be facing. So IPC metrics. Ongoing quality assurance is a critical component of healthcare. There are two primary metrics that we routinely assess in IPC across VHA. The first is same-day access, which is the percentage of patients who are new to the IPC team who were seen on the same day as their PCP or other medical team member. The idea here is to approximate warm handoffs. The second major metric is IPC engagement. This is the percentage of primary care patients on a particular panel or across the system of care that have been seen by an IPC team member within the last 12 months. So after the pandemic started, it became apparent that the same-day access metric, as defined at the time, would no longer be useful in providing an accurate picture of what it was intended to measure. So changes were needed. Prior to the COVID pandemic, the same-day access metric did not consider telephone-based services or clinical video telehealth visits into the home to be same day, like a warm handoff, as it was felt it was probably not really a true warm handoff. But given the shift to virtual care that was required during COVID, it really became the norm for these handoffs to occur through virtual platforms. So the metric was updated to include both telephone and clinical video telehealth services to the home. Now, no updates were needed to the IPC engagement metric, as that metric already included all modalities of care. Okay, IPC training. So often BHPs really have no formal training in integrated primary care when entering into the role. To meet this identified need, the VA developed a multi-phase competency-based training in integrated primary care for BHPs. The training consists of 2 phases. The first is 15 to 20 hours of self-directed content, and that's a prerequisite to the second phase, which is a 2.5-day in-person training. The in-person component provides hands-on clinical skill development centered around interactive role play practice and multidimensional assessment. On the last half day, the participants are required to demonstrate their competence through live role play demonstrations using standardized patient cases. Nearly 2,500 professionals from a variety of disciplines were trained using this structured training program from 2017 through early 2020 when COVID hit. So when the pandemic hit, it became clear that we had to use a different approach to continue to build competence for the professionals entering into integrated primary care. So the 2.5-day in-person training was restructured to 5 4-hour days of virtual face-to-face training. And that was really to reduce video fatigue. You couldn't really be on camera for 8 hours straight. That would just be way too tiring. So we transferred what would typically be a kind of turn to your neighbor and grab a partner situation to setting up personalized breakout rooms through the training for folks to pair up and practice the skills. To replicate what would typically be a trainer moving from pair to pair of the participants and giving live feedback, trainers were assigned to breakout sessions to assure all the participants received the observation time and the in vivo feedback that's so important. And then the final day of training was done in a similar manner where each participant engaged in personal live role play demonstrations using those standardized patient cases via video. So some key features of the shift were that the content between in-person and virtual was essentially the same, aside from some routine content updating. There was a training and how-to support materials that we developed and provided to the trainers to help orient them to the virtual platform and the logistical processes. And then feedback from the trainers revealed that it was very helpful to have roles clearly delineated ahead of time. So things like who's going to run the slides, who's taking attendance, who's monitoring the chat, those things, who's going to monitor which breakouts and when, that was very important. Another critical piece was an equipment pre-check for everyone involved. This helped to keep things on track in terms of timing and minimized any of the same day IT crises that can happen. And then the participant handouts were also updated to be more accessible electronically. So from September through December of 2020, 14 separate 20-hour virtual trainings were held, training 300 integrated behavioral healthcare professionals from a variety of disciplines. The results demonstrate that the virtual training platform was effective. 87.7% of virtual participants passed their initial role plays compared to 89.5% of those, which was the rate for those held in person. Participant feedback revealed that the virtual training environment is an acceptable alternative, but folks would still prefer to have that in-person experience over virtual. But all in all, virtual training is an effective alternative and has some additional benefits over in person, including reduced travel cost, expanding the reach to those who might not have had the opportunity to engage in the training at all if it was only held in person. And then it also serves to familiarize BHPs with that virtual setting. So it really adds to their clinical skill set. Okay, I'm happy to take any questions during our discussion time after we hear from Dr. Stacy Obaid, who'll be speaking next.
Wonderful. Thank you. Thank you. All right. Okay, here we go. So again, this is just a little bit about who I am and my context. I have my hands in a few different things with clinical services and primary care, as well as training and some research. And so I'll be speaking from the clinical services / clinical training aspect context for this portion. So for the next few minutes, I'm going to be focusing on the best practice adaptations of integrated primary care locally, what we have done in my context, and I'd be curious if it's similar in your context, and you can type in the chat box as I'm going through some of the contextual changes as I'm certain many of you had similar changes as well. I'll talk a little bit about supporting our primary care team members and how we can be supported as well. Some of the panelists briefly touched on that as well. And then, of course, how health equity plays into all of this. And again, I want this to be as interactive as possible. So please type in the chat box if something sticks out to you or a question arises as we transition into the Q&A portion. So this picture is my context. I am in downtown San Antonio. This is the building where our family medicine residency continuity clinic is. And there are a variety of services in this building. There's some historical context as well that I'll share in just a moment, but there's a lot of services in this building. Pediatrics is in this building, internal medicine. We have an HIV clinic. We have specialty care clinics like pulmonology, ENT are in this building. There's a lab in this building. There's X-ray, CT scans, MRIs, urgent care for across the lifespan. So there's a lot going on in this building. And so we're not alone necessarily, but some of the changes that I'll talk about how COVID is continuing to impact our patient population is still is happening even today. And so the zip code where our clinic is in is 78207. And if you're not familiar with this part of Texas, that might not mean much to you, but to give the history, you might identify with this given where your patient population is located. And again, we're in downtown San Antonio, so a bit further south from where our academic health center is located that we're attached to at UT. And this zip code has historically been had the highest rates of poverty for multiple generations in the San Antonio area. A lot of our patients live in this zip code as well, so they're within a couple of blocks from our clinic. So some walk to the clinic, some take the bus or via trans is what we call it, our via transit system to get to our clinic. But multiple generations have been in this zip code. And so given the socioeconomic, at least historical framework around the population that we serve, that you can imagine, a lot of social determinants of health impacted and still impact the patients that we serve. Access to care was something that we had to get really creative during the pandemic to figure out how to provide care in a safe way, given the option for virtual visits was very low, given a lot of our patients didn't have broadband access, still don't have broadband or internet access, have a limited number of minutes on their phone. And so it's between, do I save these minutes for calling loved ones in an emergency, or do I use what little minutes I have to be on a phone call with my primary care team? And so a lot of those decisions had to take place early last year, as there are a lot of unknowns with COVID-19. And so this is the context that I'll be speaking from. And so I'll be curious if some of you have similar patient populations that just had a lot of barriers that were around even before COVID came. COVID just made it even more interesting in how we delivered care to our patients. So I wanted to make sure and make mention of the National Academy of Medicine's release of the high quality primary care document that came out in May of this year. And I'm curious if people have heard of this. You can type yes or no in the chat box if this is something that you were aware of, or if this is the first time you're hearing of this document. If it is the first time you're hearing of this document, I'd highly encourage you to take your cell phone and scroll and scan your camera over this QR code to take you to the website to review this white paper. It is incredibly powerful, and it gives us an updated definition of what primary care is from the 1994-1996 definition that was released. They give an update to that. The white paper itself is a couple of hundred pages if you'd like to go through that, but there is an abbreviated 3-page document where you can get an idea of how high quality primary care impacts team-based care and how behavioral health shows up and is delivered in the context of primary care. And so a lot of important work that applies to us as psychologists who are part of the primary care team. This is the revised definition of what they have now created, which they've added this whole person piece. They've added the equitable healthcare piece that wasn't there before. And they've added this piece on interprofessional teams. So all of that in the old definition of what primary care is was not there. So in and of itself, if primary care is truly practiced to this level of what's on the screen, care is equitable. People have better access to care provided by teams, not just a primary care provider in a solo practice anymore, that there is behavioral health, that there are dietitians, that there are clinical pharmacists, that there are community health workers. There are multiple entities that are part of the patient's care approach. On the previous slide, I put it here a couple of times. So you have multiple chances to scan your phone over this. All right. So they made some recommendations that are what they call a call to action that heavily apply to what we do as psychologists in primary care. But I wanted to highlight this piece of designing interprofessional care teams. And within the white paper, there is a section specifically related to integrating behavioral health into primary care. But I think this really shows where primary care needs to be, where this is the standard of care and not something that some people get access to. If you're in a particular clinic or particular part of the country where you get access to having someone like us on your care team in addition to other disciplines, but that this is the standard across the board. And so that's really what it's going to take to have healthcare that is equitable and accessed easily by anyone who is seeking care. They also have these other pieces here that I won't spend too much time on, but they're important enough to discuss about payment reform, which was mentioned earlier, community-based training programs, training our learners where patients live is huge. And then hopefully having our learners stay in the area where they train, especially in some of these areas that are have high shortages of primary care team members to take care of the populations that are there. And then another piece that I won't go in too much detail with, but having a primary care research agenda, which is huge. ARC is our main access point that is specific to primary care. And even then, a lot of the work that they've put out hasn't necessarily been hyper primary care focused. So all of these things together, I think, can really impact care teams in the care that is delivered to patients. So I wanted to bring up a few questions that fit with this context of how has care changed, how have we adapted? And again, as we transition to the Q&A portion, I would love to hear if this has been similar for the folks, for you all, when you had to adapt in the early stages of COVID. And I think the biggest changes, which a lot of the panelists have already mentioned, is just the delivery of care. With the rise in telehealth and how telehealth is done with these. I love the virtual warm handoffs. If it's possible with our population, it wasn't necessarily possible. And so we did a lot of our care in person still, even before a lot of us were vaccinated. And so this next piece, how has primary care assisted primary care practices, or how has IPC assisted practices with some of the challenges? And the big two challenges that I have noticed and what I've seen somewhat consistent in the literature is the increase in trauma and grief related to just the immense amount of loss and role transitions, frequent role transitions that patients, communities, and healthcare providers have had to endure and continue to endure, since we're not out of the woods by any means with COVID. And the second piece is the discussion of vaccines. What's the role of primary care in the discussion of vaccinations in general, not just the COVID vaccine, but their vaccine hesitancy was around before COVID. It'll be around after COVID. And how can we take in some of the historical frameworks that might be impacting vaccine hesitation and keep that in mind as we're serving our patient populations. And so having more conversations with team members as well as patients about vaccines is something that I have noticed in my own practice has increased tremendously over the past 18, 19 months. What challenges may arise in the future? And how can we be there to help with these challenges? I think one of the biggest things is the access to care issue, which just our sheer presence in primary care, practiced in a way that is consistent and practiced with that high quality primary care definition could help with some of the challenges to accessing care, as well as when people do access care, making sure they're getting care that is one that is evidence-based and easy to access when they do seek out care. And so that's one of the biggest things that I have seen a change in, as well as, of course, the possible increase in trauma that we see after huge stressors that happen in our communities. And then this last question I have before I turn it over to our moderator is for our marginalized, historically excluded populations. And again, I love that definition of high quality primary care. If primary care is practiced that is in a way that's consistent with that definition, in and of itself, we would be able to impact care for populations that otherwise go without care, don't have access to care, have trouble getting to a clinic, don't have a way to do televisits, but still need help. That we can be able to do that from a team perspective, where we have our community health workers that are our extensions in the community that can give us information that we can't get in a clinic visit, that really give those contextual pieces that are often missed in visits. So honestly, to sum that up, I would say if care is practiced and consistent with the new definition of primary care, I think we can get there with reaching our historically excluded groups. So with that, I believe it's time for us to get into Q&A now.
Thank you, Dr. Obaid. If anyone wants to ask questions either through the chat or just by unmuting themselves and asking aloud, all three of our panelists are happy to take questions at this time. Maybe one question that we could ask as before we wrap up here, in terms of, primary care services long-term,
Is Madeline frozen for you guys?
Yes, I
I'm
didn't
like,
hear
I
the
didn't
question.
know if it was mine. She left us with a cliffhanger.
She did.
Oh. Any other questions?
I think we lost her.
Yeah.
Oh, there she is. Hi, Madeline.
There she is.
I apologize, my internet just went out. Glad I'm back. Sorry about that.
We didn't hear your question.
No worries. We didn't hear. You left us with a cliffhanger.
No worries. Just as a final question before we wrap up here, How do you think COVID has changed primary care services in the long term? We know how rapidly things changed, but what about the long term?
Yeah, I think the change with telehealth that's here to stay, for especially for systems like my health system. I'm in a large academic health system, and we didn't utilize telehealth really all that much for a variety of reasons. A lot of it had to do with our patient population, but now we're getting creative with ways to at least protect our patients who are immunocompromised, or have transportation issues, trying to stratify who has access to telehealth and who possibly needs to come in. So I think that telehealth piece is something that I think has changed for the long term.
I would echo that. I think that's one of the biggest changes that we've seen in VA, and that will continue on, is that it isn't a question of kind of getting care back to the way it was. It's kind of how do we use these lessons learned from COVID and transform healthcare into the future, having learned a lot very quickly.
Thank you. And we actually have one question in the chat. Any recommendations for how to advocate for developing a new primary care behavioral health program now that hospital systems are reluctant to start new programs, potentially due to financial strain caused by COVID?
I think, Robert, I think the first thing I would share that National Academy of Medicine document with your hospital team, because that sets precedence on how primary care is practiced in the United States. And there's a huge team-based care component, and a whole section of that document is on behavioral health integration in primary care alone. And so to me, that's a great starting point, is having a conversation around this is where primary care should be. And if we're not there, how do we get there, as at least a jumping off point to have the conversation? That's what I would throw out there.
I would agree, Dr. Obaid, starting with some, just providing the background of where integrated primary care should be, and such as that document and other supporting research on patient outcomes, and et cetera. I think it'd be really helpful for your hospital to see that.
Yeah, patient outcomes, cost effectiveness, provider, like primary care provider satisfaction. So you're more likely to retain your primary care providers if you have an integrated primary care service.
Yes, Brian?
Yeah, thanks. I figured I'd jump in. It's such a quiet crowd and you guys are doing a really good job. So I'm in a setting where I work for a hospital, and I'm the director of behavioral health with family medicine. So I'm integrated in a primary care clinic. And then I'm also integrated with family medicine in a clinic twice a week. And again, the challenge that people are bringing up is how to develop not just a co-located, but a true integrated program. And that's been my biggest challenge. So when I'm embedded in primary care, I have primary care docs who I can talk to, and before work, after work, whenever, and we can do, there's a small amount of warm handoffs. And I've making an effort to spread this with the behavioral health team has been so challenging, because their idea of integrated is simply co-located. So they bring people in, they'll plant them in a primary care clinic, but there's no contact at all. And so the white paper that you refer to is real. Sounds like it's another really good resource. I don't know, any thoughts on that? Any other tremendous resources?
Yeah, one quick question is, are your primary care teams huddling? Are they having regular meetings?
They're not. And that would be a big step.
Yeah, and so trying to kind of push that forward is having, and then of course having your BHPs attending that. So everybody being part of who's coming in, who are we having issues with, that's or who's overdue on vaccinations, who's like HEDIS metrics aren't looking good, whose A1Cs are out of range, and really coming together as a team to kind of think that through, but making that a regular occurrence.
Yeah, that's challenging
Once-
one in our clinic, in the residency clinic and in the primary care clinic. But there, no, I understand the usefulness of it, but
Mhm.
changing that
It's a
model and
challenge.
trying to convince them to make time for it on top of, everything else that they do that seems there's no time for.
Right.
Yeah, it's a work in progress.
Mm.
Hey, Brian, I sent you my email address. I'm in a similar context, also being in a residency clinic, so I'm happy to talk offline about concrete strategies to help with training programs.
Great. I'll touch base with you. Thank you, Stacy.
No problem.
All right. I thought you'd understand that.
Yeah, I do.
All right. Well, thank you.
Well, thank you so much for your participation, just so that we allow everyone to get to their next hour engagements. I would like to, on behalf of the Clinical Health Services Council and the Society for Health Psychology, to please join me in giving a huge thank you to our panelists for taking the time to share their wisdom with us today. And to thank you to all of our members in the audience for your attendance today and engagement. Please feel free to email us at apadiv38@verizon.net with any questions. And a quick reminder to renew your Society for Health Psychology membership for 2022 if you have not yet done so. This will enable you to participate in the teleconferences, webinars, listservs, awards, and other benefits all year. It is not necessary to be an APA member to join Society for Health Psychology. I want to thank everyone for your time and attention today, and we look forward to seeing you at future society events. Thank you very much and take care.